Welcome to Ellie Scrubs In. In this walkthrough, we're reviewing the steps of a laparoscopic incisional hernia repair, a minimally invasive approach to reinforce defects in the abdominal wall, most commonly following prior surgeries. We'll focus on the key steps, instruments used, and important considerations that surgical learners need to know. Step 1. Patient positioning and port placement. The patient is placed supine under general anesthesia. A Foley catheter is inserted to decompress the bladder, and an NG tube may be used if the stomach is distended. After sterile prep and draping, pneumoperitoneum is established to 15 mm mercury using either the Varus needle or Hassan technique, depending on surgeon preference. Ports are placed in a lateral or diagonal configuration, usually away from the hernia site. A typical setup includes one 10 to 12 mm port for the camera with a 30-degree laparoscope and 2 or 3 5 mm working ports, spaced widely for triangulation. Pearl. Place the initial port well away from the prior incision to avoid inadvertent entry into bowel adherent to the abdominal wall. Step 2. Adhesiolysis and exposure of the defect. Dense intra-abdominal adhesions are often present due to prior surgery. Using laparoscopic scissors, electrocautery, or an advanced energy device, such as a harmonic scalpel or ligature, adhesions are carefully lysed to expose the hernia sac and surrounding abdominal wall. All bowel and omentum must be completely reduced from the hernia defect. Pitfall. Incomplete adhesiolysis risks mesh entrapment or missed bowel injury. Move methodically and avoid excessive traction. Step 3. Measurement and mesh sizing. The defect is measured in both the transverse and vertical dimensions using a laparoscopic measuring tape or marked instrument. Mesh selection is based on providing at least 3 to 5 centimeters of overlap beyond the margins of the defect in all directions. Meshes commonly used include composite meshes designed for intraperitoneal placement, often with a visceral barrier side facing bowel and a tissue ingrowth side facing the abdominal wall. Pearl. An undersized mesh leads to a higher recurrence rate. Always measure under pneumoperitoneum to account for true abdominal wall tension. Step 4. Mesh introduction and positioning. The selected mesh is rolled and inserted through a 12 mm trocar or via a small mini laparotomy incision. Once inside the abdomen, the mesh is unrolled and oriented correctly. It is then temporarily secured in position using graspers and temporary transfascial sutures at the corners that are passed through the abdominal wall with a suture passer. Care is taken to ensure the mesh lies flat and centered over the hernia defect with proper overlap. Step 5. Mesh fixation. Fixation can be achieved using a combination of 4 to 6 transfascial sutures, typically pre-placed through the mesh, or tackers, either absorbable or non-absorbable, spaced 1 to 1.5 centimeters apart around the mesh perimeter. This provides dual-plane fixation, reducing the risk of mesh migration, curling, or recurrence. Pearl. Avoid placing tacks below the arcuate line, which is the point where the posterior rectus sheath ends, typically located about halfway between the umbilicus and the pubic symphysis. Below this line, the posterior abdominal wall is thinner, and tacks or sutures may injure nerves or vessels, increasing the risk of chronic pain. Step 6. Desufflation, port site closure, and final inspection. The abdominal cavity is irrigated, and hemostasis is confirmed. Pneumoperitoneum is slowly released while observing mesh positioning. Port sites greater than 10 mm are closed using a fascial closure device, such as a Carter-Thomason or endo close, often under direct laparoscopic vision, to prevent inadvertent bowel or omental entrapment. These sites are closed with absorbable sutures, such as O-Vicryl or PDS, in a figure of 8 or interrupted fashion, to reduce the risk of port site hernias. All skin incisions are closed with subcuticular absorbable sutures or tissue adhesive. Post-operative course and recovery. Most patients are discharged within 24 to 48 hours, often same day if pain is well controlled and there are no complications. Patients are advised to limit heavy lifting for 4 to 6 weeks, but can usually resume light activity within a few days. Early ambulation is encouraged to prevent DVT and improve recovery. Final thoughts. Laparoscopic incisional hernia repair offers patients smaller incisions, faster recovery, and lower wound complication rates. It requires meticulous dissection, secure mesh fixation, and attention to detail to prevent recurrence or chronic pain. Thanks for scrubbing in with us today. For more surgical walkthroughs, subscribe to Ellie Scrubs In and explore our growing library of general surgery videos.